Hi everyone, my name is Keshni Ramina. I'm doing Diploma in Occupational Therapy. I'm studying at Kuala Lumpur Metropolitan University. Here, I'm going to present my case study for pediatric demography data. My patient name is A. He's an 8 years old boy. He born on 2008, a male and Hindu boy. He's staying at KL. His dominant hand is right hand. Date of referral is 4th December. And purpose of referral is for multi-purpose returning. And diagnosis is autism and epilepsy. Introduction. What is autism? Autism spectrum disorder is AD and autism are both general terms for a group of complex disorder of the brain development. These disorders are characterized in a various degree by difficulty in social interaction, verbal and non-verbal communication, and repetitive behaviors. Signs and symptoms of autism. Spoken language delay, speech development, for example speaking less than 50 words different words the age of 2, or not speaking at all, frequent repetition of the said words and perhaps speech that sounds very monotonous or flat, preferring to communicate using a single word, repeats, being able to speak in a sentence, respond to the others not responding to their name be called, dissipates, having normal hearing, reject cuddle initiated by a parent or caregiver although they may initiate cuddle themselves, reacting unusually negatively when asked to do something or someone else. Signs and symptoms. The interaction with others, not being aware of other people's personal space or being unusual intolerance of people entering their own personal space. Little interest in the interacting with other people, including children or similar age, not enjoying situations that most children of their age like, such as the birthday special preferring to play alone rather than asking others to play with them, rarely using gesture or facial expression when communicating, avoid eye contact. The behavior having repetition movements such as flapping their hands, rocking the back and forth, or flicking the fingers, playing with the toys in repetitively unimaginative ways, such as lining the blocks up in order of color and size rather than using them to build something, preferring to have a similar routine, or getting very upset if there are changes to this routine, having a strong likes and dislike for certain food based on the texture and the color of the food as much as the taste, unusual sensory interests. For example, children with ACDs may interest toys, objects, or people inappropriately. Causes of autism. There is no single causes for autism spectrum disorder, but it is generally accepted that it is caused by abnormality in brain structure or function. Brain scans show the difference in the shape and the structure of the brain in the children with autism compared to the neurotypical children. Researchers do not know the extra the causes of autism but are investigating a number of theories, including the links among the genetics and medical problems. In many families, there appears to be pattern of autism or related disability, further supporting the theory that the disorder has been genetic based. While no one gene has been identified as causing autism, research for regular segment of genetic code for the children autism may have indicated it may experience that some children are born with a insufficient of autism, but researchers have not identified a single trigger that causes autism to develop. Other research are investigating the possibility that under certain conditions, a cluster of unstable genes may interfere with the brain development, inhibiting autism. Still, other research are investigating the problem during the pregnancy and delivery health. whereas the environment factors such as viral and infection, metabolic imbalance, and exposure of the chemicals. Is epilepsy. The cells in the brain known as neurons connect electric signals and communicate with each other in the brain using chemical messages. During the seizure, there are abnormal bursts of neuron fire off electric impulse which can cause the brain and the body to behave strangely. What are the causes of epilepsy? Epilepsy can start at any age, but it most often begins during childhood. It is often not possible to identify a specific reason why someone develops the condition, although some cases, particularly those that occur later in life, are associated with damage to the brain. How epilepsy is diagnosed? Epilepsy is most often diagnosed after you have had more than one seizure. This is because many people have a one-off epileptic seizure during their lifetime. The most important information needed to make a diagnosis is the description of your seizure from yourself and someone who witnessed the event. Tests may also be carried out to help to determine which area of your brain are affected and look for potential causes. Personal history of AIDS. He likes to eat crunchy food so much. He loves to play slide in center. Most of the time he will spend there in the slides. He stays with his family and daily his parents. His mother will send him to center for therapy. His favorite food is carrot. Daily he will eat carrot and also the fruits, the grapes, raspberries. Those things are his favorite. He will eat as a snack. And also he like rhymes influences by them to calm down him during play therapy. Whenever we sing a song, he will calm down. So that is one of his favorite songs. Family history. Her A father and mother, and A is 8 years old. And A's father's name is R, and A's mother's name is J. Social economic states. According to the patients, the financial of the family is normal and no problem about supporting the child. His parents willing to pay for a therapy session at her school in the center. Medical history. He diagnosed epilepsy and autism. He does not take any medication. He is physically good in general health. His physical is good and it's all it's okay with everything. Social history. Pre-profits. A don't like to make friends with others. Nowadays, post-profit, A likes to make friends with parents in the therapy center. That is a good improvement in A. Education. Recently, A taking special education class at the school that is situated in the therapy center. So he are performing good from my observation in the center school. Evaluation. Subjective assessment. He easily gets distracted with the environment. He is seeking for movement behavior. He likes to go around and explore all the things around him. He likes to play with the sand. He loves the sands very much because he wanted to play in the sand daily. He likes to make noise and singing rhymes, and also he asks others to sing for him during play therapy so that he can work on and cooperate to complete the task play. Objective assessment. Part 1. Occupation performance areas. Occupation performance areas have two areas, that is activities of daily living and instrumental of activity living. To assess this area and area, I use school function assessment to assess the area and area. School function assessment to assess the area and area. You can have a look on the slide that I assess from my client. Summary of school function assessment. He can't perform well his activities of daily living and instrumental activity living without forms because he have a weak muscle, a very weak muscle, low strength. So right now we are doing a strengthening activity to improve his ADL works and overall works to improve his body as well. Part 2 of evaluation occupation performance components. In OPC have four areas that is sensory, fine and gross motor, cognitive and social, psychosocial. Sensory. For sensory, we're using sensory profile assessment to assess the sensory. For fine and gross motor, we use P-body development motor skill to assess the fine motor and gross motor. And for cognitive, school function assessment is the assessment to assess the cognitive. And also for psychosocials, we still use school function assessment to assess the psychosocials. Sensory profile assessment, auditory processing. A can work with the noise background. A enjoys stranger noise, seek to make noise but do not too loud. A will respond when a name is called even the background is noise. Visual processing. A becomes frustrated and place him in a dark room. He will try to get out from the room, and he also becomes frustrated when trying to find things in the compromising background is a messy room. He will cry if we place him in a dark room. Vestibular processing. A seek all kind of movement, and this interferes with daily routine. Comes his cue. He likes to walk unconsciously in chairs. He likes to shake the all the things in environment he in. Tactile processing. Express distress during grooming, washing hand, combing hair, toothbrush. Display unusual need for touching certain toys, surface or texture. Personally touching object and neighbors any object in his hand all the time. Oral sensory processing. A. Chew and lick on non-object food. He shows strong preference for certain structure and taste, such as crunchy. He likes to lick all the things surrounding him whenever he go lie down or stand. Also, everything he will lick. All the things surrounding him, everything will lick. Proprioception processing. A. Take movement or climbing risks during playing the combinations of personal safety. He won't bother about his personal safety. Whenever playing the slide, he will try to jump here, jump there, and like holding like a monkey. It's like he never worry about his safety. Whenever we place him in the swing, he try to jump from the swing, and even monkey bar also still stay. Monkey bar is very high, but he's still trying to jump down to escape from the monkey bar because he don't like the creeping on the monkey bars. Olfactory processing. Most of the time he smells his things before he hears. He likes to smell, lick everything in all the objects he will lick and smell. He likes to do the things. He is olfactory seeker, tactile seeker, proprioception seeker, oral seeker, auditory seeker, vestibular seeker, and visual seeker. All the senses, seven sensory is seeking behavior. The second area, fine motor and gross motor from the part 2 of occupation performance components. For fine motor gross motor, we use P-body developmental motor skills. P-body Peabody developmental motor skill has six subsets to assess the client motor skills, but I use four subsets to measure my clients. The subsets that I use is stationary, locomotion, object manipulation, and graph sims. Peabody developmental. The first subset is the stationary. This subset measures a child's ability to social control of his or her body within his center of gravity and retain the equilibrium. A raw score for stationary is 39 and his age for stationary is 21 months. The second one subset is locomotion. This subset measures a child's ability to move from one place to another. This action measure including crawling, walking, running, hopping, and jumping forward. The raw score for locomotion is 108 and his age and the locomotion is 24 months. The third subset from the Peabody developmental motor skill is object manipulation. This subset measures a child's ability to manipulate the balls. Examples of the action measures include catching, throwing, and kicking. Because these skills are not apparent until a child has reached the age of 11 months, this subset is only given to children aged 12 months and older. A raw score for the object manipulation is 21 and his age of the object manipulation is 25 months. The fourth subset in the Peabody Developmental Motor Skill Assessment is this subset measures a child grasping. This subset measures a child's ability to use his or her hand in beginning with the ability to hold an object with one hand to progress up to action involving the controlled use of the fingers of both hands. A raw score of grasping is 42 and his age of grasping is 20 months. The third area is cognitive functioning from the part 2 of evaluation occupation performance component. For cognitive functioning, the assessment that I use is school function assessment. I have a look on the assessment that I carry out with my clients. They call an attachment. Summary of the cognitive school function assessment is A needs prompts to remind his performance his work, where to place his things and what to do next and etc. Because every time we have to guide him to do this and that. If not, he will just mingle around, never do any works, just playing slide, that's all. The fourth area is the psychosocial assessment that I use to assess the psychosocial is school function assessment. That's an attachment of the assessment that I assess my clients. You can have a look on my attachment on the slides. Summary of psychosocial school function assessment. A does not show interest in making friends but no eye contact. Sometimes he will follow the instructions given by the therapist and group interaction also. Based on the mood everything for him. Problem identifications, occupation performance areas. For Ariel, unable to undress himself. For sensory, mouth, non-food objects. Fine motor and gross motor abnormal pencil grip. Cognitive, unable to understand the basic steps. Psychosocial, avoid to communicate. Intervention, treatment goals and plan for activities of daily living. Short-term goals: A will be able to take off his shirt with minimal verbal prompt independently in 1 month. Long-term goals: A will be able to put on his shirt with minimal verbal prompt independently in 3 months. Treatment plan and goals for sensory. Short-term goals: A will be able to demonstrate improve the modulation of the oral sensory system by mounting less inappropriate objects during abstinence session with minimal verbal prompt in 1 month. Long-term goals A will be demonstrate improve the modulation of the oral sensory system by mounting one inappropriate object during a treatment session with gastric problems in 3 months. Treatment plan and goal for fine and gross motor. Short-term goals A will be able to improve his hand strengthening so that he will be able to form a pencil grip in order in 1 month. Long-term goal A will be able to draw a circle and diagonal, vertical and horizontal line independently in 3 months. Treatment plan and goals for the cognitive. Short-term goals A will be able to demonstrate understanding of basic instruction. Do not go there, sit down, stop licking with minimal verbal prompts in 1 month. Long-term goals A will be able to follow one series of 3 instructions. Take off your shoes, put on your shoe in shoe racks, and put your bag in a cupboard. Once enter the therapy center with minimal verbal prompts in 3 months. Treatment plan and goals for the psychosocials. Short-term goals A will be able to smile and say thank you when any therapist, parents, carers, or family member favor him with minimal verbal prompts in 1 month. Long-term goals A will be able to improve his social skill by being together with parents and center with minimal verbal in 3 months. He will be able to join circle time in the center together with parents with a minimal prompts in 3 months. Patient accept good financial support, good family support, parents good income plan to the OT. Model of practice, person, environment, occupation, PO model. This model, it has been indicated that occupation performance results from the dynamic relationship between people, their occupation roles, and the environment in which they live, work, and play. It is a client-centered approach but equal emphasis is placed on the environment and occupation when designing intervention. PEO definition: person, dynamic and changing with the skills and ability to grow over the time. Environment include the physical and social culture institution factor that influence occupation performance. Occupation includes healthcare, productivity, and leisure. Frame of reference: cognitive frame of reference, assessing level of cognitive function and providing tasks appropriate to the level, aim to describe the cognitive limitation caused by chronic illness, identify and remaining function ability so the expectations of the client are realistic. Sensory integration frame of reference purpose to provide evaluation and intervention designed to identify and prevent and remediate defects related to the child sensory and perceptual skill, motor and prosthetics, and sensitive and related pattern of some functional performance. These methods are used to achieve and overcome goals of occupation therapy to improve the child health and participating through the engagement in everyday activities or occupations. Rehabilitation frame of reference: the independence in achieving through adaptive device, and environmental modification, wheelchair modification, ambulation aid, adaptive procedures, and safety education. The focus of this frame of reference is to enable and create use more independently for the person in safety and in timely manner comparing the ideal, engaging in meaningful leisure occupation, having the need skills. Developmental frame of reference: the developmental frame of reference is based on the theory of human development in and across all skills areas: physical, cognitive, psychological, emotional, psychosocial. Aims to identify the higher level motor, social, cognitive skill in which a client can engage and facilitate improve in function from the starting points. Graded activities so that the client can achieve them but in slightly challenge. Help close the gaps in the area in which client is unable to perform. Humanistic frame of reference is concerned about the individual's view of life but takes a more holistic perspective. The frame of reference and changes occur through the relationship with others, and it seems as virtual and complex treatments and unlimited to success rehabilitations. Biomechanical frame of reference. Key reference are used to conjunctions with the various others with enabling the OT to assess and identify a client occupation performance with various activities of daily living. Biomechanics looks into a client physical capacities such as movement and muscle strength and endurance. Treatment implementation. Problem 1, unable to undress himself. Treatment is training in ADL, undressing. The target behavior is child is able to independently remove t-shirt from his body. Frame of reference, rehabilitation frame of reference, and biomechanical frame of reference. The condition method that uses is backward training to undressing, and the criteria that used is for 15 minutes. Rational is backward training allows a child to experience a strong successing has more steps since either a child complete the nearly taught step immediately followed by the steps she has already mastered. This can minimize the anxiety and provide a child with a sensory complementation. Precautions environment should be free and casual distractions. Problem 4, unable to understand the basic steps. Treatment is knowledge is not about simple step with a modeling or any any expressions. The terminal behavior is able to understand the simple instruction steps. The frame of reference that I use for this problem is developmental frame of reference and cognitive frame of reference. And the condition is create a simple activity to develop the basic understanding steps, guide all activities that do every day, give reward when they complete any steps even when not enough, encourage to do works so that he can learn more steps. The criteria to use is all the time and every day. Rational by applying the basic step understanding he can perform his work independently so that he can learn new and more in his studies. Understanding basic steps is very meaningful because he can perform any other outdoors activities. The precaution is ensure the child understands way of doing and assist the supervise the child always. Ensure the instruction given are simple and clear. Treatment plan. Problem 2. Mod non-object foods. Treatment is sensory integration therapy or play therapy. Uh, Target behavior is decrease the amount that non-object food molding. Frame of reference is sensory integration frame of reference. Condition and the method is chew hard candy, giving from water bottle with the biofilm and unpleasure through the straw. Alternative chew toys, blow bubbles, blow whistles or other instruments. So this kind of activity can control him from the licking or putting non-object. If he make him concentrate to one different from the taking and everything. So if we create some new activities, it can be lesser and can prevent from the leaking and treating all non-object things. Rational if solo non-object fate is as a virus lead to blockage method that used to prevent non-object for object may lead a decreased behavior because the kids will focus on the particular task that given methods that we use can divert the mind from walking. Precaution make sure the environment clean and suitable place to play for kids. Problem 3. Abnormal pencil grip. The treatment is polishing to prepare for gripping the pencil and writing. Target behavior is able to perform a proper pencil grip. The frame of reference that used for this problem is biomechanical frame of reference, developmental frame of reference, and rehabilitation frame of reference. Condition and the method is improve the muscle tones, improve the small muscle tone of hand, working in a vertical surface help to strengthen the whole arm which is important the foundation skill for riders. Heavy work activity develop the end arm muscle, push-ups or catwalk, swimming or um, Walking, well walking, so it will help to strengthen the muscles. And the criteria for these activities is 30 minutes for every day. Rational pencil grip can be used to help a child to achieve a maturity. Precaution is environment should be secure and free from the casual distractions. Problem number 5. Avoid to communicate. Treatment is social training. Through the interaction and play with siblings or friends, a child will developing social skills and interpersonal skills alongside their communication skill. Target behavior is child will communicate basic reserve and needs. Frame of reference is used as humanistic frame of reference, a developmental frame of reference, and last is rehabilitation frame of reference. The condition that use is a backward training to how to respond when adult or any others ask the question and how to repeat the answer by closed-ended or open-ended steps and a rational ability ability to communicate effectively is a key skill and the better we are it is the better our quality of life will be. We begin communication from the moment we are born and letting our mother know that we have arrived with our first cry as a child development is important to nurture their communication skills so they are capable to express themselves clearly and confidently in all aspects of every life. Ensure for precaution, ensure the eye contact and ensure the instruction is simple and clear. Home problem. Encourage patient to do practice handwriting at home. Encourage caregiver upon placing step to teach the child. Encourage the patient and parents to do activity like wheelbarrow walk and push up to strengthening the hand. Educated the caregiver upon some method to calm down the child when they get too active. A child will learning to communicate by watching and listening to their parents and mimicking the words and acting. The more you communicate with your child, the earlier, the quicker the will be learn the skill. The parents have to be spend time with the aim to improve his communication skill. Future plan is to continue the treatment as per published. I will assess the patient if possible, and also if possible, come and visit some physio center in future. Cognition and rehabilitation. A should not miss this appointment to cognition therapy. A is very able to follow instructions that given to after the treatment section. Medication able to decrease OCD. The reference. Thank you for listening and look after this my presentation. Thank you so much.